Well, hi everybody. We're going to discuss Chapter 8 and Chapter 9. I'll be doing them in increments, so they'll be shorter. All right, so let's start the nursing process and patient-centered care. So what is the nursing process and what does patient-centered care mean? All these terms that we need to really figure out and understand what it is. So first we'll talk about the nursing process. Let me just get this started. All right. So the nursing process, and this is a very important slide to know. So quality safety education for nurses, QSIN. So the buzzword is called QSIN. If you look it up online, you can go to the QSIN website, and they have all sorts of initiatives and research and stuff. But basically, we want to make sure that us as nurses, you guys as nurses, as you're going in as nurses, are providing safe care and complete care, meaning covering everything you need to do to provide safe care. So there's certain rules, or not rules, but let's say competencies, as it says up here, things that we as nurses need to do, and as you go out into the nursing field, need to do in order to be a safe nurse. Okay, so let's go over some of these. So first is patient and family-centered care. It seems very self-explanatory, but just remember the key word is making sure the patient has the source of control. If they are able to, let them be the source of control. Have respect for all of what they want, get to know them, and we talked about this a little bit in culture. So patient and family-centered care. Yes, we want the family involved, but remember we run into situations where the family wants to take over. You have to always remember that the patient is the source of control, that you always ask them. It's a different thing if they're, are deemed incompetent. That's a completely different thing. But while they can make decisions, let them make decisions. And then the next competency is working together. So collaboration is a newer buzzword too over the last couple of years. Collaborating, that just means I'm working with you. You as a nurse are working with pharmacy. You are working with pharmacy and the doctor all together to make sure that this patient is taken care of the way that the patient should be taken care of. Traditionally, we've worked in silos. Think of a silo. Here, you got the doctor over here who's not talking to the pharmacist, who's not talking to the nurse, who's not talking to the social worker. We don't want that anymore. We need to work together because with really sick patients, they're seeing multiple physicians. There's different nurses coming in, respiratory therapies coming in, and we all need to talk to each other to make sure we're doing things the right way, as well as having respect for the patient's needs. One other example I can think of is a patient that, let's say, just had heart surgery, they're recovering, and we're waking them up all night. The nurse has their vitals at, the medical assistant does vitals at midnight, and then the nurse is going in to do assessments later, and then respiratory therapy comes at 2, the nurse comes back, and then labs coming in. So it's not really working together. And yes, this does still happen on a daily basis in hospitals, but we have to think of the patient. I used to work on a cardiac step-down unit, and I made sure my patient got some sleep at night. That's how they're going to heal. All right, so evidence-based practice. Now, those are more for advanced degrees, like myself being a nurse practitioner. So I diagnose and I treat patients based on evidence-based practice. What does that mean? That means that there's studies done to determine how I should treat a person or what's recommended based on research. So an example would be, let's see here. Okay, mammograms. There's a lot of research done that shows that mammograms are beneficial for women ages 50 and older. There is inconclusive evidence. They haven't really come out with a good recommendation to say that they could have them every year at 40. So right now it's every other year, starting at age 40 and then age 50 every year. And then colonoscopies, once you reach 85, it's not recommended anymore. It's because these are all based on evidence-based practice, research that's done. All right, moving on to quality improvement. Quality improvement, we want to improve quality. So there'll be people there's nurses that have their CNLs, that's an advanced degree, that can monitor how we deliver care. And is it working? What we are doing, is it working? Safety, that's self-explanatory. We want to minimize harm. And informatics is all your technology, all your information for communicating. So make sure that you really get to know these slides and really understand this slide. It's really important. All right, let's go to the other part of the nursing. Let's go to nursing process. We have, and I think that you should have had this introduced or covered already in one of your other classes, nursing fundamentals. So we have assessment, diagnosis, planning, implementation, and evaluation. So we're going to go through each approach here. Subjective data. All right, so let's start with assessment. There's two different things I want you to understand too, is subjective data and objective data. Subjective data is what they tell you. Objective data is what you observe and what you assess, okay? So it's completely different than the subjective. So a lot of people have a hard time deciphering the two in the beginning. Anything that they can tell you, that's subjective data. So, for example, all of this list here, which I'm not going to go through, but you have to make sure that when you're getting data from a patient, when you're assessing a patient, let's say you're working in the hospital and you get a new admission, this is what you're going to find out. You're going to ask them all of this. You may have some on file, but it's still subjective data because you wouldn't know otherwise. You're trying to find this out about the patient. Then we go to the objective data. This is what you assess, observe, and do. This is you listening to their heart and lungs. This is you looking at their labs and results. The patients can't tell you what their heart sounds like, right? And they can't tell you what their CBC is. They can't tell you what is in the physician notes. You're doing the vital signs, so they can't just guess, yeah, my pulse is 82 right now without checking. So you check that. And then if you're observing the patient being restless or anything, you need to document patient appears restless, or patient appears angry, or he said this, and that. That's you assessing that. If the patient says, yeah, I feel really tired for the last 2 weeks, that's something they're telling you, and that goes in your this portion of it. Okay? All right, so we got assessment down. This is you figuring everything out. You're asking them all these questions. Then you're getting other data. You're doing their physical assessment, vitals, getting all that stuff. All right, so you have all the information you need, right? So now what are you going to do? You need to diagnose the patient, and there's nursing diagnoses. I use medical diagnoses. So if you come in with the cold, I say you have acute sinusitis if I determine that. But nurses have nursing diagnoses because that's going to help you care for the patient. So these are just some examples below, and you should have a list of nursing diagnoses. If you don't, please let me know, but you should in one of your other books. So anyways, anything you gathered from the previous, you're going to make your nursing diagnosis, what you determined based on your assessment. Now that you have your nursing diagnosis, you can take that diagnosis and now you can make a plan. So making the plan, that's one of the most challenging parts of it. I think planning is the most challenging because you have to set goals. So your goals need to be obviously patient-centered. They need to be realistic. They need to be measurable. And I'll show you some examples in a little while. They need to have reasonable deadlines. They need to be acceptable to you and the nurse. The patient should make some decisions with that plan. And you can share with whoever needs to be shared with. And again, the important thing, it needs to be very realistic. So I'll give you an example. Let's just say someone comes in with lung disease and you want them to go home on oxygen. And so you need to set a goal for them. Or let's just say let's take that back. You want them to go home without oxygen. And so you can't just say patient will be discharged at home without oxygen. That's not specific enough. You need to say patient will be discharged home, will be discharged to home and have a pulse oximeter of greater than 93% by the day of discharge. So as you can see, it's very specific. And it has to be realistic. So if this patient's a smoker or has a long time history of respiratory illness, then it might not be realistic if I say patient will have a pulse ox of 98% on discharge. Pulse oximetry, that's checking your, they put that little thing on your finger and checks the amount of oxygen on your hemoglobin to see if you are breathing okay. Normal is 95 to 100 for a healthy person. If you have chronic lung disease, and a lot of smokers after a long period of time, you're lucky if you get 90, 92. So again, that's talking about being realistic. So here's another couple examples. The patient will independently, all right, so independently administer prescribed dose for, that's being measurable, 4 units, because you can't just say just insulin. You have to say the amount of regular insulin by the end of the 4th session of instruction. So that's being very specific. The patient will prepare a 3-day medication recording sheet that correctly reflects the prescribed medication schedule by the end of the 2nd session of instruction. So you see how detailed this is. And look at these examples. These are all part of planning. So this is what you want your patient to do. So you're making your plan. Now we're going to implement the plan. You're going to carry out the plan. You're going to actually educate them. You're going to give them their medications, as the goals would say, based on your diagnosis. You're going to give your patient care and just any intervention. So when I say intervention, basically anything that you wrote in your plan or your major goals. So these are goals, right, which is all part of your planning, which are based on your nursing diagnosis. And you're going to carry those out. So there's some really important factors, because you can come up with a plan with the patient, but really, are they ready to learn? So they have to be ready to learn. It's no different than quitting smoking. If they're not ready to quit smoking, there's no sense in going through anymore. You give them the 1-800 quit line and say, here you go, I'm here if you need me. So with this kind of patient teaching, you have to be ready to learn. Everybody must be engaged in it. Timing is important no matter what. What if they're just come up from a nap? They might be tired, or before a nap they might be tired. You don't want to talk to them while they're trying to eat lunch. Making sure the environment is quiet, and watch for language barriers. So the patient has to be ready to learn. What factors promote patient teaching? Making sure it's at their education level, talk layman's terms. Several sessions. There's many people, especially elderly people, that you really need to break up the sessions. If you're trying to teach somebody to check their blood sugar and they're elderly and have a difficult time, and they really are confident and want to learn, or not confident about learning, make them confident. Say, let's break this up. Let's do small successes. Don't overwhelm them with one session, and then they're not confident and they go home frustrated and they can't do it. So let's say, all right, today we're going to learn how to put a drop on the strip, or, so several sessions. If we need to use community resources, such, for example, outside resources for elderly to help them do checks in the home or Meals on Wheels. And then you have to make sure the patient understands the instruction. All right, so patient teaching, general, side effects, self-administration, diet, and culture. So these are all the things that you're going to keep into account. So any side effects of anything. Are they going to give their own medication? What's their diet going to be? What kind of cultural issues or barriers would they have? All right, so now we've finished with planning. Evaluation, did it work? Were the goals met? Were the teaching objectives met? Meaning basically the things that were the goals during planning, and then as you implemented them, your teaching, did they do, or did you guys accomplish what you wanted to accomplish? Do they need follow-up? Do they need referral to resources? Because many times you'll find out more things they need by actually carrying out your plan with the implementation. And then you're going to document that you achieved the goal. All right, so I'm going to go through this. Hold on, I'm going to go to a next slide.